Okay, you see this?
Yep, I can see it.
Okay, so malignant epidural spinal cord compression. I texted you this slideshow, so you should have it.
Oh, awesome. Okay.
So it also looks a little prettier than the previous one, so that's nice. Um,
Yeah.
so basically, malignant epidural spinal cord compression. So you could get like a Cauda-Equina syndrome, really depends on where the compression is, right? That would be closer to the Cauda-Equina, of course. Um, and that would be dysesthesia or anesthesia between the saddle regions, as well as loss of bowel bladder function. So urgent imaging. Patients may be able to walk and move their legs with cauda-equina, right? It's something that's more in the pelvis. But this is an emergent situation. Pancoast tumor, it's a superior sulcus tumor that invades the lower brachial plexus. We discussed this already. You can get Horner syndrome, weakness, etc. I'm not going to go through every little term here because time is fleeting,
Yeah.
but you have your self-study here. So denosumab and the biphosphonates. Um, Key is they inhibit osteoclast-mediated bone resorption. They don't replace radiation in systemic cancer therapy or analgesics, but they can help, but they can lead to osteonecrosis of the jaw, atypical fractures, and renal monitoring for monitoring for hypocalcemia. And if they have kidney issues, you have to be careful.
Okay.
Superior hypogastric plexus. It's basically in front of the L5 vertebral body. You could go transdiscal, you could go paravertebral to get there. You're getting the viscera. And just remember ganglion and parts for the perineum.
Okay. And you said there's typically not a lot on the inferior
Yeah,
hypogastric.
I actually never seen a question on that.
Okay.
So I'm not going to get too crazy over that, but ganglion part, you could go transcoccygeal, you could go paracoccygeal. Most people go transcoccygeal through the ligaments. It's easy, usually. Um,
Okay.
okay, so it's radiation to the bone. It could help palliate bone pain. Erector spinae plane block. This is like a paravertebral getting more than one level. Um, Thoracic epidurals is, you know, the risk of epidurals. I don't need to spend too much time on this, right?
Yeah.
Fascia iliaca can help with hip fracture. You're getting the lateral from cutaneous nerves as well, but you're not so close to the femoral artery, so it's not such an invasive shot. Tap blocks, well, you're getting somatic pain. When it comes to taps, it's somatic, not visceral pain. Um, my partner yesterday told me that there was a study showing tap blocks don't work, but to be honest, they probably do work. They just need to be done right, and they're often not done right, meaning you're injecting within the muscle and between itself and its own fascia, as opposed to between the fascial planes of which two muscles?
So you said you told me sartorius. You said
No,
your
no,
lateral.
that's sartorius. That's the fascia iliaca. I mean, that's the lateral cutaneous nerve.
Oh,
It's going
yeah.
on the tap
Uh,
plane. Where do you put your needle for a tap block?
I'm not sure.
Okay, between the internal oblique muscle and the transverse abdominalis muscle.
Okay.
Peng block. Do you remember the nerves involved again?
Yes. I'm just writing this down. Um, the peng block was, I wrote them down. Um, the femoral obturator and accessory branch of the obturator.
So remember the articular branches of the femoral obturator and our accessory branch of the obturator.
Okay, articular branch of
Mm-hmm.
femoral.
Paravertebral block, you can get pneumothorax, right? You're also pretty close to the spine, but you could use this to treat thoracotomy pain, breast surgery pain, zoster-related pain, intercostal pain, and one shot can get multiple levels if you give enough volume. Cluster headache acute treatment. Well,
Oxygen
right.
or
High flow,
tryptan.
high flow oxygen and The cluster headaches are trigeminal autonomic cephalgia with severe unilateral orbital, supraorbital temporal pain lasting 15 to 180 minutes, plus ipsilateral autonomic symptoms and restlessness. Okay, verapamil for cluster prevention. Calcium channel blocker, and just worry about heart blocks or monitor the EKG. That's the most pressing thing. It could also include constipation, edema, hypotension, bradycardia, and PR prolongation, and AV block as other side effects. Hemicrania continua, a unilateral headache disorder with exacerbations and autonomic symptoms that responds absolutely to indomethacin. SUNCT, SUNA, short-lasting unilateral neuralgiform headache attacks or cranial autonomic symptoms, and the SUNCT includes conjunctival injection and tearing. SUNA has autonomic symptoms without necessarily both. On the boards, very short duration autonomic attacks that distinguishes the SUNCT and the SUNA from cluster headaches and migraines. So just think of short or quick and like S and S for short, S for SUNCT or S for SUNA. So you can just associate that as short.
Okay.
What's the name of the syndrome? The other name?
Eagle syndrome.
Yeah, right. So throat pain, ear pain triggered by swallowing. You can have syncope, bradyarrhythmias. This is very commonly tested on the board, so make sure you know it.
Okay.
Okay, TAC. What is that? Trigeminal autonomic cephalgias, the unilateral headache disorders with cranial autonomic symptoms. Timing helps make the diagnosis. So clusters are 15 to 180 minutes. Hemicrania is 2 to 30 minutes and indomethacin responsive. That's paroxysmal hemicrania. And the SUNCT, SUNA are the seconds to minutes, many daily attacks. Hemicrania continua is continuous indomethacin responsive. So if you hear absolute indomethacin response, it's paroxysmal hemicrania.
Okay.
Catastrophizing, maladaptive cognitive emotional response to pain characterized by magnification, rumination, and helplessness. CBT for chronic pain. It does not prove malingering if it works. It treats biopsychosocial consequences of persistent pain, even when nociceptive input remains. Functional restoration. You want to do rehabilitation model that emphasizes graded activity, exercise, behavioral stages, education, return to work, vocational planning. Function should improve before pain is zero. Long-term absence, repeated imaging without red flags, passive modalities only, and opioid monotherapy worsens disability. Somatic symptom disorder, well, it's not malingering or fictitious. It does not require absence of organic disease. It's distressing somatic symptoms plus excessive thoughts, feelings, or behaviors related to those symptoms. Opioid risk mitigation. Aberrant behavior does not automatically equal addiction, but cannot be ignored. So you got to address it. You don't always need to discharge the patient from the practice. They don't want to see you abandoning the patients who have needs, like substance abuse needs. Doesn't mean you have to
Mhm.
continue their opiates, but they don't want you kicking them to the curb.
Okay.
Urine drug testing limitations. So negative opiate screening in patients prescribed oxy may be false negative, so it does not automatically mean the patient is playing games.
Okay.
Controlled substance schedules. Schedule 3, where most mu agonist opioids for severe pain. I'm sorry, buprenorphine is Schedule 3. Schedule 2 is where most of the mu opiate receptors agonists are, and methadone is Schedule 2. Regression to the mean, small and controlled case series with dramatic improvement does not prove efficacy. Ask about blind and control group allocation outcome assessments. It's a statistical phenomenon where extreme measures tend to be closer to the average on repeat measurement, even without a true treatment effect. Sensitivity, a proportion of true positives is detected by a test, and specificity, a proportion of true negatives are correctly excluded. Number needed to treat, number of patients who need to be treated for one additional patient to benefit from compared to the controls. Calculated as 1 divided by the absolute risk reduction or absolute benefit increase. It's used it uses absolute, not relative differences, and you have examples here. Um, Booby trap for the boards. Do not calculate a number needed to treat from relative risk reduction, convert percentages to decimals, and use absolute difference. Okay, hopefully you won't need to do that. Type 1 and type 2 error. Type 1 is a false positive conclusion that an effect exists when it does not. Type 2 error is a false negative conclusion that misses a true effect. Intention to treat analysis. It's when participants are analyzed in a group to which they are originally randomized, regardless of adherence, crossover, or protocol deviations. It preserves a prognostic balance created by randomization and estimates real-world effectiveness rather than idealized efficacy. So board trap, if spinal cord stimulator randomized patients never receive implant but are still analyzed in the SCS arm, that is the intention to treat. Hazard ratio, relative measure comparing the instantaneous event rate between groups over time in time to event analysis. A hazard ratio of 0.7 suggests the intervention group has a lower hazard of the event than the control group, assuming proportional hazard. So it means it does a hazard ratio of 0.7 does not mean 70% of patients are cured. It means a relatively lower hazard at any given time. Once again, never seen this on the boards. I wouldn't stress too hard about this. This is just some statistics. Stellate ganglion, yes, it's near Chasternet's tubercle C6 landmark. The ganglion actually is at C7 and lower, but we target C6 to avoid pneumothorax. And you're near the blood vessels of the neck, the major blood vessels. You could also get vascular injections, recurrent laryngeal nerve, phrenic effects, esophageal puncture, neuraxial spread, seizures, LAST, pneumothorax. We never really do these bilateral because of those side effects. Horner syndrome, ptosis, meiosis, anhidrosis caused by cervical sympathetic block. Lumbar sympathetic, you get increased limb temperature, not motor deficit. You get sensory nerve, norsensory nerve destruction or urinary retention or Horner's. You just get usually warmth and pain relief of the lower extremity with temperature increase. Suprascapular nerve, once again, branch of C5, 6, no sensory innervation, innervates infraspinatus, supraspinatus, and 80% of the shoulder joint. Neuralgia paresthetica, um, sensory only, anterolateral thigh, and it is lateral to which muscle? When
Or
you block it,
say that one more time.
the lateral femorocutaneous nerve is blocked lateral to which muscle?
Oh, the sartorius. The sartorius.
Beautiful, beautiful, beautiful. Cluneal nerves. It's a dorsal rami of L1, 2, 3, sometimes 4 and 5, and they run over the iliac crest and they can be compressed at the fibroosseous tunnel, manifesting as buttock low back pain, and even can have radiation down to the leg. Genicular nerve, we block the superior medial, superior lateral, and inferior medial branch. Why don't we block the inferior lateral branch of the genicular nerve, or why don't we ablate that?
Yeah, so that you don't hit the pudendal nerve and then cause a foot drop.
It's funny you said pudendal because I thought the same thing, but we both did that because it's another name that starts with a P, not pudendal. Pudendal is
Other.
for the pelvis, right?
Oh, perineal. I don't know why
Yes,
did
I
I,
thought the same exact thing because I think we were just
oh,
talking
that's
about pudendal
I,
all day, and that's that's what we were both thinking. Anyway, it's peroneal. Okay,
yeah.
and here's well, the next slide is pudendal. Maybe you were subconsciously projecting. Anyway, so perennial pain worse with sitting, relief with standing. If it's the toilet seat. So this is Nante's criteria that's used to diagnose pudendal neuralgia. Pregnancy and pain procedures. Board trap pregnancy is not a blanket of never to treat, but you have to be very careful and elect which therapy always coordinate with the obstetrician. So acetaminophen here, they're saying, is okay, but then there's a lot of controversy now about that with autism. I
Uh-huh.
think you should the boards will hopefully stay away from the controversy because, yeah, and just avoid elective procedures on pregnant women if you can. Um, I always talk about PRP being contraindicated in pregnancy, but that doesn't make any sense to me. So um, it's still a relative contraindication. However, I think if I was pregnant, I would probably prefer PRP than steroids, but I guess we'll maybe that will evolve into real guidelines that kind of tell us what to do when it comes to that sort of thing.
Yeah.
Anyway, that's it. I hope you got something out of this.
Yeah, this was excellent. These were definitely more, kind of thought provoking and um yeah, this was really good.
Oh, good. Well, I'll try to create something along this line for the next time. And as of right now, next week should work out good for me. So if it works out good for you, we could do Wednesday again.
Okay,
Okay.
that would be great. That's
Well,
perfect.
have a great week,
All
and
right, thank
we'll talk.
Okay, sounds good. Thank
Take
you.
care.
Take care.
Bye.
Bye-bye.